Good afternoon, ladies and gentlemen. I have the pleasure of introducing Dr. Sherry Tapp for today's seminar. Dr. Tapp received medical education at the University of Texas in San Antonio. She completed a residency in psychiatry, followed by the fellowship in geriatric psychiatry from the University of Texas Southwestern Medical School in Dallas. Dr. Tapp is board certified in general psychiatry with subspecialty in geriatric psychiatry. She practices at St. Agnes Hospital Behavioral Health and also sees patients at the Wupon Memorial Hospital. Please join me in welcoming Dr. Tapp.
Okay, so did I get this on? Okay. My voice is not great today, so I will, if anybody has trouble hearing me, please let me know because I will do my best. Okay, so physician, I didn't realize that this was going to be such a difficult topic to talk about when I agreed to do this. And actually, I think I volunteered. I'm not really sure how I did that. But we'll talk about how that came to be. But okay, so I have no disclosures, and we're not going to talk about anything medicine-wise or anything today. So I'm just going to get the big elephant out of the room. The reason that I'm doing this is because I want to dedicate this to Dr. Whitmore, Julia, and the entire family. After his suicide, I felt really bad about it and couldn't figure out really kind of why. Part of it is I came from a culture of we had to talk about stuff like this. So the first time that I really had an incident where I needed to talk about it because I had an incident was in residency, and this was not about a physician, but when you're a resident at the VA hospital there, you take the crisis calls for the entire, basically a quarter of the state. So I was on a crisis call one night, and my husband awoke to me saying, "Put the gun down." Like really loud, pretty much screaming, "Put the gun down," over and over again. I was talking to somebody on the phone on a crisis call. And this man actually shot himself while he was on the phone with me. Fortunately, he shot himself through his pannus, and there was, he didn't even have to have surgery or anything. They just basically explored the wound in the emergency room. But it was about 6 hours that I ended up being on the phone with this gentleman, between talking to him beforehand, getting the police to his house, which was about 200 miles outside of Dallas, and then getting the police to go in the door because he had a gun, and they didn't want to go in the door with him having a gun. So, all that being said about that incident, I went in the next day, we talked about it, all this stuff. I went to go see him on the medical unit the following day, and he didn't remember anything. He didn't remember calling me, he didn't remember speaking with me, he didn't remember shooting himself. He was so intoxicated that he had no idea about the entire incident. But I needed to talk about it. And so as a residency group, we spent one of our, what would have been our educational lectures talking about it. And I have found that very helpful to talk about any kind of mental health issue that ends in some sort of tragedy and so I thought that this was something that needed to be talked about. And so doing this in an educational kind of way is the best way that I could come up with how to do this. Okay, so we're going to talk about the mental health statistics regarding health professionals, licensing issues and mental health treatment, and specific to Wisconsin. We're going to discuss physician health programs and discuss how and when to get treatment. Okay, so 6% of physicians reported feeling suicidal during a 12-month period of time. And this is a study from about 5 years ago. 40% said that they did not seek treatment because of fear of repercussions. And another big proportion said that they did not seek treatment because of the stigma of illness. That means about 20,000 physicians probably need mental health care and are not getting it. About 400 physicians commit suicide annually in the US, and that number is probably increasing. The statistics, if you look at them over a period of time, it does look like those numbers are increasing. The physician rate of suicide is double the general population, and it's particularly bad for women. Women's have suicide rate at the same as male physicians, and that is not the general population. The general population is women commit suicide a lot less. So that rate is extremely high. After accidents, it's the most common cause of death, of suicide among medical students. And there's a bunch of studies about medical students, but a third of them met criteria for alcohol abuse or dependence. 35% of them reported having suicidal ideation that were dependent upon alcohol or drugs. And so this is again a very high rate of people feeling suicidal and not seeking treatment.
Is that any different than the general population?
It's about twice the general population. So, not quite twice, but almost twice for that age group. It's 5.7 among 18 to 29-year-olds, and so 9.4% is almost double that. So this was a study done by Dr. Catherine Gold, and she has a large group of women physicians that she does studies with. And about 50% of them said that they thought that they met criteria for some mental illness, but had not sought any treatment. And most of them were, again, because they were afraid it would be reported to the licensing board, or that they thought that it was embarrassing, shameful, or they should have been able to handle it themselves. Only 6% of people who had a diagnosis and were receiving treatment actually reported it to their licensing board. And there were a lot of stories of people leaving medicine after experiences that they had after disclosing their mental illness. Okay, so state licensing. So there is a federation of state licensing boards, and they asked, how should we be asking these questions? And so because of how it is worded, not to violate the American Disabilities Act, you really need to ask about what is going on currently. And that has nothing to do necessarily about people's past history, and it doesn't necessarily have to do with if they're in treatment right now. That basically only the idea is that if impairment is risk to patients can be inferred only from what's going on right now, not from a diagnosis or treatment alone. So you can't base this on what has gone on in the past, only what is going on right now. And there was actually one court case that determined that they couldn't investigate more into someone just because he had a history. And this was basically somebody who had an incident in medical school, was hospitalized for a short period of time, and then they were not allowing him to be licensed in a particular state because he had that 25 years before. So the APA right now recommends the language, are you currently suffering from any condition that impairs your judgment or that otherwise would adversely affect your ability to practice medicine in a competent, ethical, and professional manner? Okay, so that is, kind of more all-comprehensive, not just about mental health, about medical conditions, about substance abuse. So that is the recommended language. When they looked at what state licensing boards are doing, only a third of the states actually follow this language. About 2/3 of them were still asking about, have you ever had treatment? Okay, so I just actually copied and pasted the questions that are on the Wisconsin licensing renewal application. So actually, we are compliant with that. It says, do you have any medical condition which in any way impairs your ability or limits your practice to practice in a safe way? Okay, so we are, actually Wisconsin is compliant with that. And, you know, this question here says, are there limitations? If you don't have any limitations, you don't have to answer these two questions. So if you have limitations, then you have to answer these two questions. And most of these questions are more about, are there things that you are doing to make sure that you can still practice in a safe way? And the best example that I could find was a pathologist who's in a wheelchair, who can still perform his job without any difficulties. But he has to report that on there, that he can still practice the way he needs to practice. Okay, so then the rest of the questions are basically about substance abuse. And again, this is the idea that, you know, are you in a supervised program, and are you using substances that impair you? And again, that's asking about the current state of things. Now, they do have some qualifying things on the application, and of course this is kind of the fine print that nobody reads, but I think it's important to make sure that everybody knows exactly what's going on. So they talk about cognitive capacity. Basically, can you function cognitively, or ability to communicate and perform the tasks that you're supposed to do, and medical conditions and substances. And then currently, this is the slide that I thought was important, is that it says basically anything in the last 2 years that has impaired your ability to practice. So basically, for the Wisconsin renewal, when you're renewing every 2 years, it just asks you, in the last 2 years, have you had to eliminate anything or had any use of things that would impair your ability to practice? And the same for substances. And I'm not really going to focus on substances, but it's going to come up because they're often grouped together. Okay, so physician health programs. Ideally, they were created to help addicted physicians and health professionals be able to stay in their practice, maintain their license, without being reported to a state medical board or having any punitive measures. The goal is to keep people in practice, save their lives, save their careers, but also to protect the public. They create a monitoring program, management, advocacy. They can be very helpful to physicians who, you know, want to practice and just need to have some support, some extra support to be able to do that. They're non-disciplinary, which means they can recommend things, but they can't actually make any formal decisions about things. And the idea is that, you know, if they think you need an evaluation for something, they're going to send you to someone to have that evaluation, but they have no direct licensure authority. They don't have any power to restrict people from practice. You know, they can make a recommendation, but they don't have any power to do so. And most of the time when people are, you know, a danger to the public, they have to report that, but other than that, they're not reporting anything. I was very impressed with the statistics on physician health programs and how well they do with substance abuse, because that must be a reflection also of how they do with mental health. I didn't find any mental health statistics, but I did find some statistics. And this is a 5-year absence rates for people at 79%, and people return to work rates at 96%. So AA is about a 5-year abstinence rate of 5% for the first time you go, from the first time you go. And their return to work rates, I don't really have any statistics on that, but that's pretty impressive for a substance abuse program to have 79% people have 5-year abstinence. People are highly motivated. Now they've broadened their scope to include other professionals, psychiatric disorders, and physical disabilities and cognitive disorders. So most of the programs now are much more broad than just focusing on substance abuse. Okay, the physician assistance program that's licensed by the state through the licensing board is actually only includes substance abuse. So there is no mental health component to this at all. All of that is done within the physician health committees or programs within institutions. So this is only for substance abuse for the state. When I looked at this program, it's very intensive. Lots of paperwork and monitoring, and they want to know how many AA meetings you've been to, how many NA meetings you've been to, who you're seeing as your counselor, and a lot of information. So if you can deal with it within your own physician health program, that's definitely going to be to your advantage. Okay, so this came up like 4 or 5 times in my reading about, do physician health programs increase suicide risk? And I didn't understand what they were talking about until I really was reading the cases that they were talking about. And all of the cases that they were talking about were people who had violated their physician health program in some way or another, and they were going to be reported to the state. So almost all of the people who were here were kept out of that system for a period of time, but they had done something beyond the scope that was dangerous to patients, and so they were now placed in a position where they were likely to lose their license. So I don't think that physician health programs increase suicide risk. I think that if you step outside the bounds of those physician health programs and you're going to be reported to the state, that seems like where the risk is. Okay, so for Agnesian, I am the chair of the committee for the Waupun Physician Health Committee. And this is who is on the committee for here. And Ripon does not have one, except it's on their agenda for their next one because I did this talk last week there. So they're on the ball with it. Okay, so we're going to talk about getting treatment. So, I really think that the best place to start is to have a relationship with your own primary care doctor. Now, I know physicians are not good at having their own primary care doctors, but I do think that that's really, really important. Most physicians have difficulty putting themselves in the hands of other doctors. Myself, I kind of feel like I'm kind of being past that. I put my hands in my life in Dr. Lundberg's hands for a year and a half when I was undergoing cancer treatment. So I've already been there. I already have done that. So I can't see that would be a difficult thing for me to do. But I can see how it would be difficult for physicians to do that. And I did go to my first appointment with Dr. Lundberg with the guidelines for the breast cancer treatment in my purse. I don't think I ever told him that, but I went with the guidelines in my purse. If he didn't follow the guidelines, I was going to be. So, but having a relationship with somebody really makes a big difference. I know when I go to my primary care doctor, we talk about how things are going in our department, how things are going with stress, how I'm dealing with balancing my life. And we talk about that every time. And I really like that's a part of it. I think sometimes physicians are not likely to ask their physician colleagues those kind of personal questions. But, you know, those are the same questions, these should be the same questions you ask any patient. And if you have a relationship with your primary care doctor, then treating those things is easy to do early, because you've already had the discussion. They already know what's going on, and so the next time something comes up, it's a lot easier to bring that up again the next time. Mindfulness, you know, this is kind of the whole idea about being aware of what's going on within yourself. You know, we all know what the criteria are for major depression, anxiety disorders, but, you know, being mindful of what is going on with ourselves and making sure that we refer those people, just like if you would refer your patient who meets those criteria, you have to refer yourself, because you already know what the criteria are. Working on the stigma and embarrassment of mental illness, this is something I deal with every day with my patients. You know, I'm always trying to advocate for people to work on the stigma and embarrassment of having mental illness, getting treatment. It doesn't really matter what it is, but being able to do that and to be able to say, I've had problems with depression, I've had problems with anxiety, I'm taking medication. All of those things are really helpful. If we can do it, it makes it a lot easier for everybody else to do it. You know, burnout, I did a talk about burnout, but, you know, it's all about this whole idea of what is the professional physician and what are the things that are characteristics of that. I made a list, and I'm going to read it just because it sounds like a list of what you would have in a mission statement, right? So professionalism in physicians has to do with altruism, accountability, excellence, duty, honor and integrity, and respect for others. Well, it sounds like some sort of mission statement. Well, it is kind of a mission statement. That's what our mission is. And if you have high levels of responsibility, it makes it so much more difficult to be able to separate yourself and be able to get the help that you need. High expectations, that's something that goes on all the time. You know, the medical record, electronic medical record has been very stressful for a lot of people. Regulatory things, definitely. There's some new CMS guidelines for treating nursing home patients with psychotropic medications. It's been very stressful for me. And litigation. Now, litigation, I don't want to focus on that necessarily, but, you know, a lot of the cases that I was reading about really had a lot to do with litigation. And so if there are litigation things that are making you stressed, you have to find some way to deal with those things, and I have some references to them. Okay, so I actually read a lot for this talk, but these two are the two books that I'm going to talk about the most. One is Why Physicians Die by Suicide, and the author of this book is Michael Myers, and he actually lost one of his fellow medical students in medical school. It was a roommate of his who committed suicide on Thanksgiving break. And so he's kind of dedicated his career as a psychiatrist to helping physicians get the mental health treatment that they need. And this whole book is, you know, kind of written about these different topics that we've talked about, but it's written from a totally different perspective, because most of it is written actually from family members or from phone calls with family members of people who've committed suicide. And so it's really, I mean, it's a very emotional book, but it's very helpful, and, you know, it's a quick read. You know, I pretty much reread the whole thing last night. It's not a difficult read. It's an emotional read, but it's not a difficult read. And I found it very helpful just to be able to kind of see all the different perspectives that people have about it. You know, there's stories in here about family members wanting their physician, family member to get help. There's ones where physicians, family members didn't want them to get help. You know, about what happens to the other people in your practice, what happens to the people in a small community. There are a lot of stories that were very heartbreaking in here. A small town where 3 physicians committed suicide in 18 months, and where 2 residents committed suicide in a week. You know, so there's a lot, and this book is available in my office at any time if anybody wants to borrow it. But it's really a very powerful book, and I think that if you have any thoughts about suicide, it would be an excellent thing to read. Okay, so the other book that I read, and I actually had read this before, but I like this one. It's called The Remedy for Burnout, 7 Prescriptions for How to Make Sure That You Are Happy in Your Practice. And again, I can't memorize those 7 things, so I wrote them down on a piece of paper. So one is develop resilience, and this is what Dr. Schmidt has been working on, and what we've been trying to do is help people develop that resilience to be able to handle the things that we have to handle. So be able to have those resources to deal with stress. The stress is going to happen. The other one is practice faith. Now, this is not necessarily faith in God. This is about to be open to the possibilities. To have faith that your staff is not trying to undermine you. To have faith in what is going on around you, and have faith in your own capabilities. Cultivate self-worth. Promote creativity. This is the one that I like the most. I like to be creative in the things that I talk to my patients about, and I like to be creative in how I do things for myself. So my most recent creativity thing is, instead of trying to go on a diet, I decided I'm going to incorporate 6 fruits and vegetables every day into my diet. And I've lost 20 pounds on that, and I'm feeling very good about it. But it's not a big change. It's not trying to change anything about how I eat or how I cook. It's just incorporating those things and making sure that I'm doing it on an everyday basis. So I've already got 3 down for today, so it's not doing really well. But the idea is to be creative about how things can work out better for you, and how you can deal with stress in a positive way. Foster support. You know, I really like this quote that it says, "It is the responsibility to care for each other as we do our patients, and support each other in that way." Embrace compassion. I like the things that they talk about going back and looking at the things about why you went into medicine in the first place. Now, if you went into medicine for the money, it's probably not going to be helpful, but I don't think that most people go into it for the money. They have some passion about it that can be very helpful to people. And the last one is encourage connection. And that's you know what I really want to be able to talk to everybody about, is finding those connections among each other, and again, fostering that support between each other. And this book is available in my office too. Okay, so I have some resources here. I said we're not going to talk a lot about litigation, but I did find an excellent resource for people who are having litigation issues. This www.mdmentor.com had excellent resources. They will set you up with somebody who can be helpful to you. A lot of the people that they were setting you up with were people who were lawyers and physicians. So they had both degrees, so that was it was very interesting that they had people with both perspectives on it. So that was an excellent resource for people. The other one is the American Foundation for Suicide Prevention. And again, this is an excellent resource. I mean, I give it to my patients too. Those with chronic suicidal ideation really like a lot of the things that it talks about on here. That it just talks about how thoughts are thoughts and actions are actions, and it's very good website for patients as well as anybody else. Now, there's some specific physician websites, and there are a bunch of those in this book too. There are a bunch of references to basically whatever your subspecialty is. It talks about whatever the resources are for your subspecialty. But this one, and I like the name because I like language issues. So this one comes from the word melancholy, and it's specific for physician resources, for suicidal ideation, for mental health treatment. And it was an excellent resource, and a lot of the things that I read came from those resources. They have reading resources, they have people you can contact. It has a lot of resources there. There are a couple of physician suicide hotlines, but most of them are focused on residents. So like the state of New York has one for residents in the state of New York. But I give this number out all the time. So 1-800-273-TALK is, and it's a confidential suicide hotline. Anybody can call it at any time, and it is completely confidential. So they really don't even ask. I mean, you can give them your first name because it's kind of nice to talk to somebody with their first name, but you don't have to give them any information. Just somebody to talk to. And somebody to get those resources from. Okay, so I knew that this was not going to be a very interactive talk because I did it last week and I realized that it was not going to be a very interactive talk. But I do think that there are a lot of things to talk about in this, and like I said, this is kind of why I wanted to talk about it. Depression and suicide are serious health problems for physicians. Wisconsin licensing does not preclude treatment, definitely does not preclude treatment. So if you're on an antidepressant, you do not have to report that to the state board. If you're in treatment, if you're seeing a counselor, none of that has to be reported. Physician health programs are available for treatment, and I encourage people to not let the referral come from the med staff department or come from your colleague. I like it in Wapana. I kind of like it because if somebody's having an issue, sometimes they'll just come to me. My office is right there in the primary care office, so it's kind of nice. They can just walk down the hall and come in and talk to me about whatever is stressing them out. And I'm open to helping them find those creative ways to deal with their stress. And, unfortunately, most of the time, the referrals are from someplace else. We are responsible for changing the culture of mental health, and it's not a surprise that we have to start with ourselves to be able to do that. And definitely, I want to encourage people that help is out there. I wish I would have said that to Dr. Whitman. So, Dr. Giesecke, you cannot tell Chris that I put my information on the slide, okay? So my nurse would be very upset if I put out this information, but I feel it's so important. So that's my new email address with SSM, my office number, you can reach me through the secure messaging system and my personal cell phone. Okay, so I wanted to be a resource to you, not only because I think what happened with Dr. Whitmore is a tragedy, but I definitely don't want to see anything happen to anybody here. And that I want people to know that there is help. So I'm going to stop with talking, and I am going to open it up to people to talk about whatever they want, but I would really love to hear people talk about Dr. Whitmore. So I miss the most from Dr. Whitmore when he would walk in from the parking lot or when he would walk out to his car, he was always whistling. And I guess I parked like right by him, I don't know, but I would hear him whistling all the time. And I kind of miss that in the parking lot. That I never hear anybody whistle anymore in the parking lot. So that's what I miss about Dr. Whitmore. Does anybody else want to talk about Dr. Whitmore?
Well, I miss, he used to cut out the funniest cartoons from the newspaper.
Mhm.
And he and I talked about it every day, and we shared the cartoons, the funniest ones. We had lunch. And then the room had all the drug company, pharmaceutical company came out with all these funny products, toys and stuff, pens. And he had a collection of them. He had a collection of them that he saved all the funny, body for pens and stuff. Stuff up from Jesse. Made sound when he pushed them.
Yeah.
Can I ask a question? What all is reportable to the state medical board? So we know it's, treatment for depression, anxiety, some of these things is not reportable.
Right.
But what is reportable?
Anything that puts patients in danger, that is the reportable stuff. I don't want to give you a list of things necessarily because I can never give you a complete list of things, but basically anything that puts patients in danger. So if you're making poor decisions because of what's going on, then that could be putting your patients in danger. So really, it's about the dangerousness of it that is really the reason that things get reported. When people are receiving treatment, there's no danger to their patients. That's not a problem. This is, the reportable stuff is the stuff when people are, not using good judgment, or they have a medical problem or a psychiatric illness that impairs their ability to practice appropriately. So it's really the danger part of it, I think, is the most important part.
I think the reportability is only on who you apply. There's no renewal.
Well, you have to answer those questions that I had on the board. You still have to check off those questions when you do your online application. You still have to check off those boxes that say. No, those questions actually were all from the renewal application. I just pulled up my renewal application actually and copied and pasted from
The
that.
only question I have is what responsibility does a physician or a nurse have to report
Right, and again, a lot of that has to do with dangerousness, I would always prefer that if you thought that there was something going on with somebody, that you would report it before it got to that dangerousness category. that you would go to the physician health committee or the med staff office and say, you know, I think there's something going on with this person, and we need to address it now, before it got to that point. But really, the obligations are about dangerousness. You know, the most common reportable things have to do with, you know, people being intoxicated at work, not showing up to work, not taking their call responsibilities, those kinds of things, where people's lives are in danger.
Also, there was a time when the medical society had the physician health program, which was confidential, and only people could sign on confidentially and without the fear of being reported to any court. There was some issue. And that was a good alternative to any physician. I think that is not available.
That is, the medical society does have some resources, but they do not have a physician health program like that anymore. And really, that's because most institutions are doing that themselves. You know, we have one here, you know, that's the idea is to be able to do it more locally. And I really think that we do pretty well with confidentiality. I mean, as far as I know, no one knows who I have monitored or who I have talked to in Wuhan. You know, no one has ever come to me and said, oh, so-and-so knows that I've done this or whatever. No one ever knows, unless they say. One of the physicians said he was so happy with the recommendations that we made that he was like, this was the best thing that ever happened to me, was me getting referred. Because, you know, the recommendations that we made him so much better. So much better. He dealt with his stress so much better, and he was very happy that he opened about that to the other members of the staff. So.
I was going to say that Mark always struck me as not only affable, consistent with his whistling, but he was a humble man, and he, I always sense, took care of some of the most difficult patients, not medically speaking, but otherwise, that would never refuse anybody.
Yes, I think he took care of a lot of his mental health patients himself and didn't necessarily refer them. And that has made it, I think, somewhat difficult for some of the people to have taken over some of his patients, because he felt confident in doing that.
I recall he was involved in the medicine department credentials committee and in the medicine department. And there would be times when a group would struggle whether we should credential somebody or not. And he would render some opinion and it would just kind of sway the group, oh, we should credential this person or not. His judgment was so practical but yet on point. And I found myself asking the med staff office when we were serving, well, what does Dr. Whitmore think? Because he would always seem to be spot on. And he showed up for every meeting. He always responded by email timely. He really cared.
Yeah, I think he was a leader in that way.
Yeah.
I agree with him. Well, if anybody wants to take over whistling in the parking lot, I would be more than happy to have somebody do that. I'm not so much of a whistler myself, but